Alright, so I am doing a presentation on pressure ulcers in the pediatric population, and just how important it is to implement a pressure ulcer bundle to help prevent pressure ulcers in the population. I'm sorry, I'm trying to get this out of the way. Alright, so what in the world is that? That is a pressure ulcer.
It's like stage 4 or 5.
No, that would be a stage 1, possibly a stage 2 pressure ulcer on the sacrum. Can you see it? So there's bruising, there's erythema, and then there's maybe a shearing from repositioning with a draw sheet. So maybe a stage 1, maybe a stage 2 pressure ulcer. So pressure ulcers are any area of skin that's damaged by unrelieved pressure or from shearing forces. This picture is a nasal cannula left on a baby's face too long, and it caused a pressure ulcer right there, the septum. So that is horrible and probably painful. We all know the pressure ulcer staging. Most common 1, 2, 3, and 4. There are unstageable pressure ulcers as well, usually ones with eschar and sloughing. And then the common pressure ulcer sites for us, it's the occiput for our kids, their sacrum, their heels, sometimes their shoulders, but back of the head is most common in babies especially. So for me, working the past 40 years with kids, 14 years in pediatrics, working with kids, their safety is very important to me. So implementing this pressure ulcer prevention bundle, hopefully will help decrease pressure ulcers, not only in our unit, but also in the hospital, if we can implement it hospital-wide. We all know there was a pressure ulcer found on our unit a couple weeks ago, 2-3 weeks ago on a patient that could have been prevented. We're not sure where it initiated, on this unit, another unit, or at home, but it could have been prevented. So there are lots of studies about pressure ulcers in the adult population. There are very few about them in the pediatric population. People, for some reason, don't believe that kids can have pressure ulcers, but they can. There is a 26.5% risk seen in kids over a year old. And it's been known that bundles, not just individual guidelines, but bundles work a lot better than guidelines, mainly because bundles are interventions, mandatory interventions that are easily audited, where guidelines are individual interventions that usually people kind of might do one, maybe not another. Bundles, you do them all together. So why should a change be made? Pressure ulcers are very expensive. They're very costly for hospitals. $70,000 per pressure ulcer per patient is a possibility. $11 billion a year in the United States alone is spent on just treatment of pressure ulcers, as well as causing systemic infections, sepsis, in a lot of patients, especially if they're leading to stage 3 and 4 open pressure ulcers. So what is the cause? We are on an ortho floor. A lot of our kids are immobile, so that is one of the most common causes. Another cause is poor nutrition, just not the proper nutrients, not enough protein, not muscle on their little bodies. External medical devices, pulse oxes that are left on too long or that are taped to their skin, the cords taped to the skin. IV hubs that are not properly padded, arm boards, blood pressure cuffs being left on when they're not being used, nasal cannulas like you saw in the picture, and then our orthopedic devices, our casts. We all have seen casts that are too tight, splints, traction devices, that sort of thing. So, in the pediatric population, this is my question that I'm asking. In the pediatric population, how does the utilization of a pressure ulcer prevention program, along with the utilization of a pressure ulcer bundle, compared to routine skin assessments, decrease the number of pressure ulcers in a 6-month period? So, I recommend implementing a pressure ulcer bundle program for about 6 months just to see if we can decrease the amount of pressure ulcers that we have on the floor. So areas of pressure ulcers, also what causes them. External devices have been found to contribute to 38.5% of pressure ulcers. Cannot speak today. 40% of pressure ulcers are found in the feet, IV arm boards, and IVs, as well as on the hands, and as y'all know, it's probably on the back of the hands from those IV hubs. This is an IV hub that causes pressure ulcer on this baby. So we have to be mindful of that. Those little white tape that comes in, that padded tape, that's what that's used for, to prevent things like that. As well as on the fingers due to pulse oximeters. Grading Q scoring, we all use grading Q scoring every time we assess a kid, every shift, every shift. So the scale, if it goes less than 16, they are considered high risk of a pressure ulcer, as we know. I don't know how many people actually pay attention to grading Q scores when they do their assessments, if we just kind of click down and keep it moving. But they are very important because they do let us know who is at risk. Those scores include mobility, activity, sensory perception, their moisture, friction and shear, nutrition, tissue oxygenation, and perfusion. And it has been shown that with interventions, the grading Q scoring actually helps to lower the occurrence of pressure ulcers. So the pressure ulcer prevention bundle includes multiple interventions, and this is what I'm recommending for our floor. Completion and documentation of Braden risk assessment scale on every shift. A physical assessment of the patient's skin being performed and documented on admission and then every shift thereafter, which the majority of us do anyway. Nutritional status assessment performed on each admission. Patients being repositioned at least every 2 hours. Draw sheets being used during repositioning. Encouraging the patient to sit up in a chair or to ambulate when they are not asleep, and then assessing underneath or rotating medical devices regularly throughout a shift. With the bundle, there has been seen a decrease in pressure ulcers from 32.86% down to 7.1%, which is a huge decrease. So obviously the use of a bundle would definitely help with pressure ulcers. So my plan for change is to recommend that we have pressure ulcer pup champions on our floor. I would recommend 2 from each shift, just to cover everybody. In case one's not here, then there hopefully will be another one in place. They'll be educated by the pneumodoscopy nurse and a nurse educator on pressure ulcer staging and their skin assessments. And then the staff is educated by the pup champions and then pneumodoscopy and then the nurse educators. The pup champions will assist and observe the staff nurses performing head to toe skin assessments. And if they see anything that's not done properly, they will either reiterate what needs to be done properly or recommend reinforcement with the nurse educator. And the pup champions will perform weekly skin assessments on high-risk patients that are already being performed on by the staff nurses, but just to make sure that nothing is being missed on these patients. And just if it's successful, from there, we will present this to the quality team who can hopefully initiate this hospital-wide. So with the weekly data, if the pup champions are doing their high-risk skin assessments every week, we'll do this for a 6-month time frame. And by the end of 6 months, if it shows that the initiation of a pressure ulcer bundle is successful, at that time, like I said, we will submit this to the quality team and hopefully initiate this hospital-wide. If it's not successful, then we will try to figure out exactly where the errors were, make those changes, and then try again for another 6 months. So, anybody have any questions or any suggestions for our pressure ulcer bundles? Anything? Thank you guys so much for listening. I really appreciate it. You guys are awesome. Thank you.